Welcome to this month's Trauma of the Month session, where we're going to be looking at the CRASH-3 trial rather than looking at a specific case presented by a trainee this month. So the CRASH-3 trial's title was The Effects of TXA on Death, Disability and Vascular Occlusive Events and Other Comorbidities in Patients with Acute Traumatic Brain Injury, CRASH-3. A randomised, placebo-controlled trial, and it was published towards the end of last year in the Lancet. So I thought we'd start off by just revising what we know about TXA and some of the trials that have come before CRASH-3. So TXA, as we all know, is an antifibrinolytic, and it's all to do with the plasminogen TPA combination, which come together to form plasmin, an enzyme that breaks down the fibrin in those organised clots into fibrin degradation products. And TXA blocks that binding of plasminogen and TPA, so it prevents plasmin formation. So firstly, let's have a look at CRASH-2. We're all familiar with CRASH-2, very famous trial. It's been around for many years now. It was a randomised controlled trial into the early administration of TXA in trauma patients at risk of non-cranial hemorrhage. Okay, so bleeding everywhere but apart from the brain. And they showed a reduction in all-cause mortality at the 4-week mark if TXA was given within 3 hours of injury. So a statistically significant reduction from 16 to 14.5% with a number needed to treat of 68. So very impressive results from the trial. And importantly, they did not show any increase in fatal or non-fatal vascular occlusive events. Moving on to the women trial. So it was another RCT into the early administration of TXA in postpartum hemorrhage. And again, they were able to show a significant reduction in death due to bleeding at the 6-week mark from 1.9 to 1.5%. The number needed to treat of 267. And again, 3 hours was their cutoff. So it was all women were given TXA within 3 hours of PPH. And again, no increase in fatal or non-fatal vascular occlusive events. And that's really important when we come to look at the CRASH-3 results as well. Now, the authors of these two trials, they combined their results into a much larger meta-analysis, which, not unsurprisingly, reproduced the same results, showing that TXA significantly increases overall survival from bleeding with an odds ratio of 1.2. And what was also really important from this meta-analysis is that a treatment delay reduces the effectiveness of treatment. So a 10% reduction in survival benefit for every 15-minute delay in treatment up to the 3-hour mark, beyond which there was no benefit. So give TXA as soon as possible. And again, they were also able to reproduce the effect that there was no increase in vascular occlusive events with TXA. Hundreds of trials into TXA now, looking at different patient cohorts and pathologies. But CRASH-3 is the first one that specifically looked at traumatic brain injury in large numbers. So the overview of the trial, what were they trying to ascertain? So in traumatic brain injury, does the administration of TXA within 3 hours reduce 28-day head injury associated in-hospital mortality? It was an absolutely humongous trial with over 12,000 patients in 29 countries, over 170 hospitals, so a huge undertaking. It was a double-blinded randomised controlled trial with intention to treat analysis. And their intervention protocol was a gram of TXA over 10 minutes, followed by a gram over 8 hours in the treatment arm and saline in the placebo arm. So the same treatment protocol as you'd expect from CRASH-2, the women trial, and many of these other trials that have gone before it. So this is really the gold standard of a randomised controlled trial. Big numbers, multi-centre, randomised, double-blinded, intention to treat analysis. So kudos to the authors really in setting up this trial. In terms of the recruitment of patients, what the inclusion criteria were, well, the patient had to have a traumatic brain injury and had to be within 3 hours of injury. Now, initially, that was 8 hours of point of injury that they could be recruited, but that was changed halfway through the trial to 3 hours of injury, and we'll talk about why and what effect that had later on. So the patient had to have a traumatic brain injury, they had to have a GCS of 12 or less, or have proven intracranial blood on their CT. So it could be GCS 13, 14, 15, but with blood on their head scan. And also importantly, the clinician who was recruiting the patient had to be uncertain of the benefit of TXA for that patient. For example, if that patient had significant extracranial bleeding, as per the CRASH-2 trial, you would want to give that patient TXA because you know there's a survival benefit. While those patients therefore wouldn't be able to be recruited to CRASH-3, because there isn't equipoise. The clinician recruiting a patient is not suitably uncertain or appropriately uncertain of the benefit of TXA for that patient. And it's important to understand that when we come to look at the results as well, because there's a relevance to that later on. So in terms of the analysis, how do they analyse the results in this paper? Well, they looked at head injury death, so head injury specific death in hospital 4 weeks after the point of injury. Their power calculation was initially 10,000, but that was increased to 13,000 later. And I'm not clear as to why that was increased. And certainly the interviews with the authors on numerous podcasts I've listened to don't go into that in much detail either. So it's worth considering why that might have happened. And they looked at in-hospital 28-day mortality, and they used 3 hours as the cut-off. So if they were more than 3 hours after the point of injury, then they weren't recruited. But keep in mind that that changed halfway through the trial. So there were about 9,000 patients who actually were within 8 hours of injury who were recruited in the early stages of the trial. And again, the results of that are interesting to look at. They also did a pre-specified sensitivity analysis. And what that means is partway through the trial, they realised that a lot of severely head-injured patients, so patients with GCS3 or bilateral dilated unreactive pupils, were being recruited to the trial. Patients that they weren't expecting to be recruited. And again, I'll talk to you about why they were being recruited unexpectedly. But before the results were analysed, before anyone had any eyes on the results, they asked the statisticians to do a pre-specified sensitivity analysis to be able to exclude these patients when they come to the final analysis, because they thought it would be relevant. And we'll talk about those in a few minutes. So first and foremost, the primary outcome measures. Well, it was 28-day in-hospital head injury associated mortality. What did they find? Well, the mortality was 18.5 in the TXA group, 19.8 in the placebo group, with a relative risk reduction of 0.94. However, the confidence intervals crossed 1 and there was no statistically significant difference. Okay, so the primary outcome from a statistical analysis perspective was negative. What about our secondary outcomes? Well, let's look at this pre-specified subgroup analysis. So if we were to exclude all of those GCS3 patients and all those patients with bilateral unreactive pupils, that risk of mortality, or that mortality rate, was 12.5 versus 14%. With a relative risk reduction of 0.89, but again with confidence intervals that just reach 1. So again, no statistically significant difference, but certainly an increasing trend towards survival when you compare with every patient in the study. However, if we look at the mild and moderate TBI groups, those with GCSs of 9 to 15, there was a significant reduction in mortality. So 5.8 in the TXA group versus 7.5 in the placebo group, with a statistically significant relative risk reduction. There were some other secondary outcomes to consider. So timing of TXA, well, the earlier you give the TXA, the more effective it is. And that was true for everybody in the mild and moderate TBI group. But if you had severe traumatic brain injury, the timing of your TXA didn't have an influence on whether or not it was statistically effective or significant. And that kind of makes sense because those severe TBI groups are probably unsurvivable irrespective of the TXA, whereas those in the mild and moderate group, the timing is going to be more important as to the effectiveness of the treatment. There was no impact on the disability of the traumatic brain injury between the two groups. There was no increased risk of complications, so those vaso-occlusive events that have been looked at in other TXA trials, but also instance of seizures. So it's safe to give TXA in head injured patients. The risk of seizures and vaso-occlusive events or disability has not been increased. It does reduce the head injury related deaths in those with mild and moderate head injury, and that's a statistically significant result. And it needs to be given as soon as possible. So in that cohort of patient where this is significantly, the results are significant, there's mild and moderate head injury patients, the earlier you give it, the more effective it is. And you could argue that this is really a pre-hospital drug. We should be carrying this pre-hospital and giving it to these patients early. But in terms of our critical analysis of this paper, well, there's a fair bit to talk about actually. So first of all, let's think about the primary outcome. Confidence intervals crossed 1 and therefore the trial was negative. Well, I listened to a really interesting interview with the lead author of this trial, and he discussed this, and his opinion was that dividing trials into either positive or negative trials based solely upon whether or not the statistics cross that p-value of 0.05 or the confidence intervals crosses 1 or not is probably the wrong way to look at trials. As these thresholds, they give an indication of whether or not something could have happened by chance. That's why we're doing this statistical analysis. And for trials such as CRASH-3, concluding that the treatment is ineffective and potentially harmful when actually the TXA is cheap, it's low risk, and it does have potential to be effective, is potentially harmful and probably the wrong thing to do. And also keep in mind that the results of this trial are consistent with what we know about TXA from CRASH-2 and the women trial, and that there is a signal, there is trend towards benefits in these more severely head injured patients. But what about this pre-specified subgroup analysis and the fact that that showed more significant results, which the primary outcome wasn't able to show? Well, the reason it happened, the reason they did this analysis, they were recruiting more GCS3 fixed dilated pupil patients than they were expecting. And when they set up the trial, they intended the recruiting clinician to have equipoise as to whether or not they thought the patient was going to benefit from treatment. And because of the nature in which trials are now run with research teams, research nurses, and busy more of these potentially unsalvageable patients were being recruited. So they had to find a way to exclude these statistically from the analysis, and this is how they did it. But keeping this in mind, can we change our practice solely on the basis of secondary outcome measures alone? Potentially not, but you've got to again take it into context, to take the analysis context. Was a TXA high risk? Was it expensive? And actually, is it a low risk, easy intervention that potentially does have benefit for our patients? Another question, why wasn't all-cause mortality used? It was in CRASH-2 rather than just head injury related mortality. Well, if you're using all-cause mortality, it contains both signal and noise. There are going to be causes of death in all-cause mortality that is not related to head injury, and therefore causes of death that TXA probably won't have an influence on, such as sepsis, for example. And if we were to use all-cause mortality, we would need much larger numbers for the trial, and therefore cause-specific mortality probably was the right outcome measure for this specific study. The next question was, why did time to treatment only have an impact on mild or moderate TBI, and why was the threshold changed mid-study? Well, early treatment is more effective because TXA is a preventative treatment. It can't do anything about the blood that's already in the heads, and therefore those patients with severe head injury who already have a large blood load are going to have less benefit from the TXA. Whereas the mild, moderate head injury patients who have a small amount of blood, who are continuing to bleed, are going to get the most benefit from the early administration of TXA. And in terms of why the threshold was changed mid-study, well, there was emerging evidence whilst the study was ongoing that actually giving TXA within 3 hours was probably better, and certainly results of CRASH-2 would support that. But what's interesting is that actually there were about 9,000 patients that were recruited into this trial, into CRASH-3, beyond the 3-hour mark. And actually, when you look at the results, it didn't actually have an effect. There wasn't an increase in mortality in that delayed treatment group. Keeping in mind, though, that the earlier you would give the treatment, the more effective it is in the mild and moderate head injury group. So what does this mean for us as a major trauma network? Well, Chris Moran, director of the Major Trauma Network, is a consultant here at this trust, and he has published his take, or rather the Major Trauma Network's take on CRASH-3 and what this means for all the trauma centres across the UK, on trauma units as well. So we should be giving TXA as soon as possible to all patients who have had the head injury in the last 3 hours and have a GCS less than 13. So if you've got a GCS 12 patient and you're within 3 hours of injury, give the TXA straight away. And ideally that should be done pre-hospital. But what about the patients who are GCS 13 to 15? Well, they need to have traumatic brain injury evident on their CT head scan. And again, as the results of this trial suggest, they need to be within 3 hours of injury. Now, there are some questions that arise from this trial that haven't been answered by the trial and haven't been answered by the Major Trauma Network. We're considering for our own practice here at NUH. Should we be giving TXA to these GCS3 patients, given that the results of this trial do not suggest there's any mortality benefit? Well, the potential for benefit is low. There is no statistically demonstrable benefit. However, there is no evidence of harm, and keeping in mind the, I say new, fairly well established now, devastating brain injury guidance, that patients need a period of prognostication in which we treat them actively if it's appropriate to do so, you could argue that we should be giving these patients TXA on that basis alone. What about after 3 hours? Well, the sooner the better, clearly, and CRASH-3 did show a 10% decrease every 20-minute delay, particularly in the mild and moderate head injury group. However, because they changed the goalposts partway through this trial, we do have a cohort of patients who were treated beyond the 3-hour mark, 9,000 patients in fact, and there was no increased risk of harm in that patient group. And that is contradictory to the results from the CRASH-2 trial. So you need to balance the results of this trial and CRASH-2 and what the injury profile of the patient is to make a judgment call there, I think. However, if it's less than 3 hours, it's a lot easier call. What about non-traumatic intracranial bleeding? Well, TITCH-2 was, again, an RCT looking at this. It didn't show any statistically significant results, but there were a fair few critiques of that trial, and a much larger trial is needed and is ongoing looking into this. So the jury's still out with regard to spontaneous intracranial bleeding. Now, this is the main question that I'm most interested in, I think. What should we be doing with patients who have a head injury? Their GCS is more than 12, so 13, 14, 15. Should we be giving them TXA before they have a head scan? Well, let's say they arrive in ED, their GCS is 13. They qualify for a head scan based on a nice head injury guidance, and they're waiting for their head scan, and we know that a delay to TXA reduces effectiveness. Should we be giving it before they have their head scan? But what about the patient, okay, and what about the patient who doesn't currently meet the criteria for CT head, so their GCS 13, 14, but they haven't hit that 2-hour mark yet, where NICE says, oh, okay, now you need to scan them. Should we be giving TXA to them? Because again, that's potentially an unnecessary delay to TXA administration. And we don't have the answer to that question yet. And there is an ongoing analysis from the CRASH-3 trial results being undertaken by the authors to try and answer this very question. So we need to watch this space. So thank you for listening. I hope it was interesting. I've pulled much of this critiquing and analysis from a number of interviews with the authors for the trial. I think for me, giving TXA early in the head injured patient group with a GCS of less than 13 is fairly straightforward, whereas a GCS 13 to 15 group requires a little bit more thought, and it'd be interesting to see what that subgroup analysis from the authors will be, hopefully sometime in the new year. Thank you very much, and I'll see you next month.